Good afternoon, friends. First of all, let me thank Dr. Jyoti Dev and his team for making me also a part of this great conference. One of the best attended by me in Kerala, as far as faculty and as well as the arrangements are concerned. Thank you, Dr. Jyoti. And the next topic is on coronary revascularization, diabetes, the newer avenues. Actually, we all know that after hearing all these talks, we all know that the fact is that majority of our patients, or about 80% of our patients, are going to die of coronary artery disease. So, as far as the final outcome is concerned, this is going to be the important talk as far as the final outcome is concerned, because Dr. Sen will be talking to us how to save our patients ultimately, and what are the new avenues in the field of coronary revascularization. Dr. Sen is the consultant cardiologist, Royal Coronary Hospital in London, and academic fellow, University of Exeter Medical School, member of British Cardiac Intervention Society, and a lot of other important positions. Over to you, Dr. Sen, for his talk.
Okay, thank you. Thank you, Jyoti Dev and team, for calling me. I hope all of you can hear me. Now that it's a little too late, I thought I should wake you up all, where probably every third slide will be an ECG, and every person sitting on the fourth position in every row, I will ask them to comment on it. Is that all right? Okay. Let's talk about some reminiscences. This is in 1991, almost 24 years ago. Actually, on the 8th of August, I was doing an ICU care as a senior house officer along with Jyoti Dev at Trivandrum Medical College. This time is the morning rounds. We do a 12-hour shift. One person will do 12 hours of night shift and the other person will do the day shift. So I had a patient with odolam poisoning. Patient came with hyperkalemia and complete heart block. So we were talking about this patient, and we said, oh, we put a temporary wire and corrected patient's hyperkalemia. Patient is all fine. So in the morning, Professor Vijayaraghavan came for rounds. Before we present the rounds, Professor Vijayaraghavan's schedule is usually he will go and examine the patient first before we say anything. So he listened to the patient, came back and said, so how severe is the mitral stenosis? Three of us, that means myself, Jyoti Dev, and cardiology tutor at that time, we were all stunned. We had no idea what's happening. So that taught me a lesson and said, okay, it's very important, irrespective of what you see on the surface, start learning and finding out from the patient, examine the patient. So that led me to cardiology. That's why I'm here as a cardiologist today. Okay, let's go to the talk. First of all, why should we bother? Okay, we are all talking about diabetes mellitus. Is there any importance of talking about it? Most important thing is the current guidelines, especially the American guidelines and the European guidelines, consider diabetes as equivalent to coronary artery disease. In prognostic terms, that means a person with diabetes mellitus has got an equivalent chance of dying in the next 12 years as compared to another person with a previous myocardial infarction. So diabetes mellitus is considered almost equivalent to a heart disease. In addition, heart disease or stroke is the cause of death for up to 65% of patients with diabetes. Okay, now as interventional cardiologists, we all love showing off what we can. So we show angiograms and say that this patient I have treated. This is a patient, an 80-year-old lady who comes with an inferior, okay, all right, looks like it's not playing, but it's not important. A patient, 80-year-old patient comes with an inferior MI. We did an angiogram, showed a right coronary artery which is occluded. We went ahead and, can you just change the slide? Should I just go back? Sorry, let me just go back and change these slides because this is not the slide I wanted. Okay, so The purpose of showing this is to tell you what's happening here. So we treated that. If you can see there, the right coronary artery is now open. What you see as a C shape is the right coronary artery. It's open and we have put a stent in. That has re-established the flow. Okay. Now what I want you to see is not what is evident on that, but in addition to the stent, if you look at the distal arteries, it's diffusely diseased. That's a pattern we see commonly in patients with diabetes mellitus. Okay. Now what I didn't show is equally important. Okay. Now this is another patient. We did the coronary angiogram. This time you are seeing the left coronary system. If you see the artery which is running to the front of the heart and going down, because it's coming from the left side and it is going anteriorly and down, we call it as left anterior descending artery, or LAD for short. Now that patient has got a significant narrowing around this area. Okay, let's skip that again. Now this is the same patient who has got severe disease extending from the top to bottom into the right coronary artery. Okay, the message is, in diabetes mellitus, you do see a disease which involves all the three coronary arteries starting from the top to the bottom. Okay, now my first question is it different in diabetics? And is there a difference in the way we treat the diabetic patients? And are we missing something? Is there any option of tailored therapy? So that's what Jyoti Dev asked me to talk. So I will skip those angiograms because we have already seen them. Now, we all know that angina is a condition in which there is an imbalance between supply and demand. Okay. Commonly, we ignore the part of demand ischemia. That means an ischemia occurring when the demand is more. Any patient with hypertension, any patient with severe aortic stenosis, or anything which increases the demand of oxygen. So, similarly, say for example, if you rev up an engine of a car, what happens is the car will need more petrol. And if that is not happening, there is a relative lack of petrol going to that engine. So the engine will struggle. Similar things, any condition which increases the demand causes an anginal problem. Okay. Now, because the majority of patients which we see are all who have got a supply problem, we concentrate for supply. Obviously, in a diabetic patient, supply is more important than the demand situation. Okay. Now, next few slides, I concentrate on the atherosclerosis and the pathophysiology. We know that the atherosclerosis is a gradual process which occurs over years. There is a lot of changes occurring in the intima and the media of the cells, and the activated macrophages which form the form cells are the most important part here. Okay. Now, in acute coronary syndrome, what happens is the plaque usually ruptures, and that attracts a thrombus and causes either complete or partial occlusion. If it is a complete occlusion, you get an acute myocardial infarction. And this slide again shows what happens between different parts of the intima and media in an acute myocardial infarction. But the changes in diabetes is slightly different. Okay, the most important part which I want to tell you is about metabolic syndrome. And because most of you are already practicing in diabetes, you know this better than me. Okay, insulin resistance is a key factor here. In addition to the hypertension and hyperlipidemia, the other thing to remember is the importance of prothrombotic state. In metabolic syndrome, the platelets start aggregating faster. There is an increased platelet activating factor inhibition production, as well as fibrinogen, and a lot of platelet abnormalities. And these cause the coronary artery disease progression faster. Okay. And this slide shows the other changes which occur. One most important thing is the production of different groups of microRNAs, and these microRNAs, especially 320, reduces the angiogenesis, and microRNA with 222 causes an increase in AGEs, that advanced glycation end products, and other ones which reduces angiogenesis as well as proliferation of endothelial progenitor cells. Together, they will reduce the vascular repair. That's why you get a diffuse coronary disease in diabetes mellitus. Now, the other important part along with this in an insulin resistance or a hyperglycemia situation is inflammation. And the inflammation causes an increase in fibrinogen as well as disease of the endothelium, and that causes endothelial damage, and the rest of the cascade follows. Now, in summary of pathophysiology, what I said so far is insulin resistance is the most important thing you need to remember. There is also vascular inflammation and altered or decreased vascular repair, and then the function changes, that's the endothelial dysfunction, and there is a prothrombotic stage which is overlapping. Together, this causes the complex coronary artery disease as well as the higher incidence of coronary events seen in diabetes mellitus. Okay? Now, that leads us to the therapeutic avenue. By the way, I haven't put any of the ECGs. That is just to scare you. So, there won't be any ECGs here. Okay, we will talk about medical therapy first. Okay, in a chronic stable angina patient, especially if the disease is not that significant, what you do is you optimize the secondary prevention. And the message which I want to give here is lifestyle modification is one of the most important part, which is going to modify the insulin resistance, and also the current recommendations tell you that optimal management of hyperglycemia is equally important, or if not more important, in treating this group of patients. Now, in the triad of hyperglycemia, insulin resistance and the prothrombotic state gives us different avenues for treating. One of them is you can use, if there is dyslipidemia, you can use statins or other agents to block the link. Similarly, with hyperglycemia, there is an important role of the newer agents but at the same time, don't forget metformin, and to prevent the platelet aggregation, currently we recommend aspirin 75 mg once daily, but you can also use any of the newer antiplatelet agents. So, if you come back to hyperglycemia, there is a lot of evidence currently available which says that treating hyperglycemia to a target, ideal target of less hemoglobin A1C concentration less than 7, improves the chance of developing or reduces the chance of developing coronary artery disease. Okay. Now there are a few slides which concentrate on what I do. That one of the treatment option in coronary artery disease is percutaneous coronary intervention, but what we see is not always the full truth. What we see is in patients with diabetes mellitus and those without diabetes mellitus, if you take all the studies, what we have seen is group of patients with no diabetes fares well with the current drug-eluting stents, but at the same time, patients with diabetes has got no significant difference whether you treat them with drug-eluting stents, one type or other. Okay, that's also seen much more significantly if the patient has got a insulin-dependent diabetes mellitus. They have got a poorer prognosis as compared to the ones without insulin dependence. Now, there are a lot of studies which compare the surgical revascularization in diabetes along with percutaneous coronary intervention. I have included only two of them. One of them is called Freedom study and the other one is BARI 2D. Freedom is a study which shows a future revascularization evaluation in patients with diabetes as well as multivessel disease. What is seen in this group is that the bypass surgery was much better than percutaneous coronary intervention in treating, but at the same time, another study which came in 2009 which showed that the BARI 2D study showed that there is no significant advantage of survival either in the diabetic patients, either with surgery or percutaneous intervention. So that leaves us in a dilemma. Is there a need to go and refer all these patients for bypass surgery? We still don't have the answer. I have put another study which is called BEST, which compared coronary artery bypass surgery along with everolimus eluting stent. That's one of the newer stents which we use, and it included more than 900 patients of Asian descent. That's why I included this. The advantage was there was a significant difference in the endpoint between percutaneous coronary intervention and CABG. So on the face of it, you see that CABG was better. This included 40% of patients with diabetes. But when you look more into the study, what we see, it was a small study they screened quite a bit of patients, but they only included 20% of the screened population in the study, and there was very slow recruitment, and they stopped the study about halfway through. Because of that, it is not powered enough, and it was also a non-inferiority study. That means it was trying to compare and say that one treatment is not inferior to the other. So it has not reached any significance in the general population, but in the diabetic population, as I showed you in the slide, it was showed as significance. So what's the problem here? What we actually see, can anybody identify this car? Okay, this is one of the electric cars which is now in market called Tesla. You must be wondering why I put that. Okay, when the electric cars came, all the manufacturers were jumping to make it, say for example Toyota or Honda. They started making electric cars. What did they do? They took their, say Toyota Corolla, they took the car and changed the motor engine or a petrol engine and put batteries in and tried to run it. What the side effect was, almost all of them will run about say 20 miles or 30 miles with one type of charging. So Tesla had no experience in making a car, but they tried to address the problem. So they said, okay, we need a car which will run 300 or 400 kilometers at one charge. So they put enough batteries on the platform and made a big car, and on top of that they built the rest of the car. So they approached it in a different form. So my message is that what we have been doing so far, in all diabetic patients, we will use them, or we will use the treatments which is actually used for patients without diabetes, and said, okay, if it works in those group, okay, can it work in diabetes? At the same time, we have forgotten that diabetic patients has got a completely different disease profile. Okay, now in view of the time, I will just cut through the last few slides. Okay, what we need is there is a tailored therapy. Now, in diabetic patients, there is a higher neointimal proliferation. The neointima is the cells which keep on lining the stents, which actually cause the instant restenosis. Okay. Now, all the drugs or the therapy which currently we use, main purpose is to inhibit the neointimal proliferation by putting drugs which are actually used for anti-cancer treatment or anti-metabolites to prevent that. Okay. Now, if we use different agents, some of them are better for diabetic patients than others. Okay. And the other important message is improving glycemic control. Okay. Now all the advantage which we are seen in the two slides which we use for surgical side group, all the benefit is based on internal mammary artery as a graph. So there is a role for having total arterial revascularization in diabetic patients, and also we need to find out, is any of the stenosis significant functionally. Finally, we come to the role of bioabsorbable scaffolds. The cardiologists among you will know that there are bioabsorbable scaffolds and they are very useful. The advantage of that is because the scaffold get absorbed between 6 to 12 months, at the end of 12 months there is no scaffold there. Obviously, there will be less of neointimal formation, as well as the endothelial dysfunction is likely to improve. We still don't have enough evidence for that. So, ladies and gentlemen, in conclusion, we talked a little bit about the pathophysiology of diabetes. Now, all the current revascularization strategies are suboptimal in diabetics, okay, because they have all been developed for patients without diabetes and then adopted for diabetics. So it's suboptimal in diabetics. So it's time for a rethink. We should concentrate on the new developments specifically targeted for patients with diabetes. Thank you.